Hello, my name is Ana López. I am dermatologist at Hospital de la Santa Creu i Sant Pau in Barcelona, and I'm going to talk about the importance of detecting psoriatic arthritis at early stages in patients with psoriasis. And I will provide you some recommendations on how to do that. And I also I will talk on how to set up a joint clinic with rheumatology. Psoriatic arthritis is maybe one of the most important comorbidities associated to psoriasis, and approximately 1/3 of our patients will develop arthritis. Usually, it will happen some years after the diagnosis of psoriasis, but remember that both diseases can appear at the same time. It has also been demonstrated that even a 6-month delay in the diagnosis of PsA may worsen the prognosis of these patients. And I think that this is the main reason why dermatologists are responsible for the screening of all the patients with psoriasis, and they have to be screened for PsA, because this is the only way that we have to prevent irreversible damage in these patients. But if we decide not to screen a PsA in our patients with psoriasis, I have to tell you that if they become undiagnosed and untreated, severe deformities and erosions will appear, as you can see here in these X-ray images of these patients with both psoriasis and also peripheral and axial arthritis. And here on the left side of these X-rays, we can see severe deformities in both distal and interphalangeal joints, also bilateral sacroiliitis, and on the right side, many syndesmophytes along the spine. So this is what is happening when psoriatic arthritis is not screened, is not diagnosed, and is not treated in patients with psoriasis. What we need to know as dermatologists is that there are some patients with psoriasis that we know that are more prone to develop PsA, as has been demonstrated in patients with severe psoriasis, patients that have a family history of psoriatic arthritis, also patients with elevated BMI, patients with arthralgia, even though arthralgia it's quite an unspecific symptom of PsA, and also patients with psoriasis and nail involvement. On the right side, we can see why in the case of nail psoriasis, there is a close connection between the nail involvement and the psoriatic arthritis in the distal interphalangeal joints. And this is the relationship is anatomic, and this is because some fibers of the extensor tendon are in close contact with the nail root, and in case that we see nail changes that are characteristic of nail psoriasis, it's not difficult to imagine how these changes are connected with the inflammation of the extensor tendon. And in fact, we need to be especially aware in patients that have risk factors for PsA, but especially in those patients with joint symptoms that cannot be explained by other diagnoses. For example, patients with heel pain, morning stiffness, and patients with arthralgia. Even though I have told you that these are specific signs, they can correspond to signs of an early psoriatic arthritis. So we need to be aware of that. What else can we do as dermatologists? There are a number of tests and scales that can be used to screen for joint involvement in patients with psoriasis, and all of them have pros and cons. All of them have been used in different settings, but sometimes they are not so commonly used in our clinical practice, and the main reason is that they are usually time consuming in our dermatologist offices. In our setting, I would like to tell you that nowadays the most commonly used scale in my country, in Spain, is the Pure-4 scale that includes only 4 questions regarding the 4 different domains of PsA. That means that it regards, the first question regards the presence or not of dactylitis, the second one regarding inflammatory heel pain, the third one regards buttock pain, that means sacroiliitis, and the fourth, the last question, regards peripheral joints. So in case of only one positive item, the patient is recommended to refer that patient to the rheumatologist to rule out the diagnosis of PsA. Recently, we have translated and validated this scale to Spanish in my country. And I have to tell you that it's really, it's commonly used in Spain, at least by dermatologists who see patients with psoriasis. And most of us use the scale, if when possible, in every time we see the patient with psoriasis, but at least it should be done once or twice a year. Once a suspicion of PsA is made, the referral to the rheumatologist is needed, but even in rheumatologic guidelines and expert recommendations, as you can see here in the picture, the co-management between the two specialties is the clue, is required to decide the best approach and the best therapeutic choice for every patient with psoriasis and psoriatic arthritis. And this is why around 10 years ago, we decided in our setting to set up a joint clinic between dermatology and rheumatology to see patients with psoriasis and psoriatic arthritis with 3 main different goals. As you can imagine, the main goal and the most important is to make an early diagnosis of PsA in patients that are referred to this joint clinic, mainly from dermatology. And also, why not to make the confirmation of psoriasis in patients with an specific arthritis, to rule out psoriasis in those patients with only signs of mild psoriasis that sometimes are not easy to recognize by a rheumatologist. Also, in one of the goals in these clinics is to make a treatment optimization in all the patients and decide which is the best therapeutic option or the best combination of therapies in patients with psoriasis and PsA. And finally, why not to improve the referral of patients among both departments, from both dermatology and rheumatology. And as I told you before, to set up a joint clinic has many advantages, but I have to tell you that also it has many disadvantages, as we will see now. For me, the most important is that we are able to make an early diagnosis of psoriatic arthritis in patients with psoriasis, and this is the main goal, and this is the main advantage of these joint clinics. But also, I have to tell you that it's easier to make a diagnosis of psoriasis because it's made by dermatologists that is specialized to detect mild forms of psoriasis. So in that cases, psoriatic arthritis can also be confirmed. And finally, one of the advantages is that we can make a consensus in the treatment of those difficult cases that we see in clinical practice. For example, those patients with multiple failures to different treatments, patients with both psoriasis and psoriatic arthritis, and with different comorbidities added to the psoriasis and the psoriatic arthritis, those patients too with paradoxical reactions to biologic therapies, etc. Among the disadvantages, I have to tell you that it's not easy to match the schedules of both specialists, because you need a dermatologist of more than one dermatologist and also a rheumatologist. And we also, the way to work is in the office is different. We have limited time of consultation, and this is mainly a problem for the rheumatologists. They need a longer time per visit per patient to make the physical examination, and dermatologists are usually, our visits are usually shorter than the ones of the rheumatologist. One of the disadvantages of these clinics is that we usually have difficult patients, and sometimes we need to follow up these difficult patients for long periods of time. And finally, we detect many comorbidities in these patients, and we need to decide which is the attitude with these patients in whom the comorbidity has been detected. And maybe at that moment we are working very close with rheumatologists, but why not to include other specialties in these joint clinics? But I would say that my main recommendation is to find your perfect rheumatologist. That means that you need to find a rheumatologist that is really specialized in psoriatic arthritis, because if you are working with a general rheumatologist, I think it will be more difficult to arrange such a specific joint clinic. So as a summary, I would like to tell you that dermatologists are responsible for the early diagnosis of psoriatic arthritis, because sometimes we will be the first to recognize the joint symptoms, and the early diagnosis is the clue to prevent the progression of the PsA. And one of the most important things is to work together with dermatologists. And my main recommendation is that find your dermatologist to set up your joint clinic. Thank you very much.